Okay, now we have a presentation by Sylvia Ozu, who is a clinical professor of medicine with University of Maryland, presently country director, University of Maryland program in Kenya. She is an infectious disease physician and educator with over 10 years experience developing successful HIV program, focusing on effective chronic care models and healthcare workers' capacity. She will be giving an overview of sustained improvement in outcomes of antiretroviral therapy over a large cohort over many years in sub-Saharan Africa. Dr. Sylvia.
Thank you very much. First of all, I'd like to thank the organizers for allowing my colleagues and myself to present our experience through this particular paper, Sustained Improvement in Antiretroviral Treatment Outcomes in a Large Cohort in Sub-Saharan Africa, backing the trend. So globally, there has been a successful expansion of antiretroviral treatment with over 9.7 million patients accessing treatment by December 2012, and Kenya contributed around 600,000 of these patients in the same time period. Scale-up in Kenya has occurred within an acute care system that was really largely used to providing episodic care with suboptimal capacity for chronic care services delivery. Published reports indicate that many of the clinics that are expanding their services in Africa are having difficulty with issues of retention, with reports suggesting that patient enrollment in recent times is associated with higher rates of loss to follow-up than previously. This kind of attrition may minimize the gains anticipated with expanded treatment coverage, which is one of the major topics of conversation during this conference. So this particular presentation is based on the AIDS Relief Program in Kenya. The AIDS Relief Program was implemented in 10 countries and is funded by PEPFAR. And within Kenya, as part of the implementation of the program, a robust chronic care model was defined for implementation and included a bidirectional community facility linkage, which was to facilitate both some elements of demand creation, but really largely to support treatment of patients within the community. There was also prioritized patient case management, recognizing that patient vulnerability is a dynamic thing and the same patient would not always need a case management approach. Standardized patient encounter tools were used from the beginning, and these fed into a large, robust electronic database that was both accessible and interrogable at the facility and program level. There was also capacity developed for data-driven process and patient care improvement, again, both at the program level, but also per facility. So the objective of this paper is to describe the yearly trends in retention and attrition rates of patients on ART in the AIDS Relief Program in Kenya. This is essentially a retrospective review of data based on an analysis of the identified data of adult patients aged more than 15 years enrolled on treatment between 2004 and 2012. Patients were excluded if they didn't have a date of birth or if they were transferred out of the program during that period of time. The year of ART start was the main explanatory variable and 12-month retention the main endpoint. Rates were derived from Kaplan-Meier survival probability estimates. Now, patients within this program did not have access to routine viral load testing, so periodically the program would carry out patient-level outcomes based on viral load measurements of a sample of patients in addition to other indicators. Between January to March 2011, such a patient-level outcome was carried out, and viral load measurements were carried out in 1,114 randomly selected patients who had been on treatment for more than 12 months with a median duration on ART of 52 months. The platform used for this was the Cavidi platform. On-treatment virus suppression was calculated and the threshold was less than 200 copies per mil. So data was analyzed for a total of 64,259 adults who had been followed up on ART for a median duration of 31 months. Consistent with cohorts in this region, 68% were female, and the median baseline age was 37 years. This is largely a rural program, so 68% of patients were attended to within rural facilities. The median baseline CD4 count for the period was 204 cells per millimeter cubed, and the on-treatment viral suppression based on this sample that was assessed of 1,114 was 93.7%. So this slide shows some of the baseline characteristics by the year of ART start. The first one is confirming that the program was largely rural and the distribution remained consistent throughout each cohort year. The second shows the WHO stage at ART start for each of the cohort years. Note that the years 2004 and 5 have been combined because of the numbers were relatively few compared to the later years. And you can see that patients essentially were enrolled over time when they were healthier. So WHO stage 1 and 2, presented in green, increased during the period. Notably, there was also a decrease in patients who did not have a documented WHO stage from 45% in 2004-5 to less than 2% in 2012. The third graph shows the baseline median CD4 count for each cohort, and this increased from 154 cells per millimeter cubed in 2004-5 to 256 in 2012. It's notable also that the proportion of patients who had a CD4 count less than 50 did not change during the time period. This slide shows the 12-month cohort retention and attrition rates for each cohort year. And the first column represents the year, the second, the number of patients starting treatment within that cohort, and the others are the retention and attrition, both mortality and loss to follow-up. And we can see that the retention increased from 83%. Oh, I didn't practice how to use the equipment. From 83% in 2004-5 to 93% in 2012. And this was driven by the mortality, which dropped from 11.6% to 4.5% in the same period, as well as the loss to follow-up rates, which decreased from 7.1 to 2.2%. This is another presentation, but of loss to follow-up over the time by year of ART start. I'll draw your attention to the light blue line at the bottom, which is the 2008 cohort. In that time, Kenya experienced a post-election chaos, which did not permit patients to attend services as they would ordinarily do, and certainly was associated with higher rates of loss to follow-up than would have been expected. This graph shows mortality over time by year of ART start. The year 2004-5 were the worst years, represented in red compared to the other years. And this is a summary of retention over time by year of ART start. So this is a summary of those three slides, showing the retention in blue. And again, note the increase from 2004-5 when it was 83% to 2012 when it was 93%. The lines represent mortality in green and loss to follow-up in red, just showing the trends over the years. And you can see the marked reduction in loss to follow-up, particularly from the 2008 to 2012, as well as a reduction in significant reduction in mortality during the cohort years. This didn't happen automatically or accidentally. This program actually implemented a data-driven improvement of patient care processes and patient care outcomes. So in 2009, with the introduction of this, the dramatic changes that are seen essentially occurred as a result of that. This is described in an abstract referred to in the blue box, which will be discussed tomorrow. So in conclusion, 12-month probability of retention improved significantly during 8 years of patient follow-up in this large cohort, representing 185,000 patient years of follow-up. A significant and sustained reduction in loss to follow-up rates in successive calendar years was observed, and this is inconsistent with several recent publications from the region in cohorts that are similar. As would be expected, there was a significant reduction in mortality rates over the year over the 8-year period, generally the patients were becoming better, the entry opportunistic infection rates were lower, and CD4 counts were higher at entry. These outcomes, and that is increasing retention as a result of declining mortality and loss to follow-up rates, as well as high viral suppression, suggest that programmatic conditions for optimal population impact of expanded ART coverage can be achieved in resource-limited settings. Thank you. I would like to acknowledge my colleagues who are part of, who are co-authors with me, and the principal investigator for the grant, as well as the organizations that have made it possible. Thank you.
I think this was a very good presentation, that you saw sustained improvement in the outcomes over the years as the program matured and people were initiated earlier on treatment. So any questions? Yes, please.
Hi, my name is Nadia. I'm a pediatrician in Nigeria. Thanks for your presentation. I was just talking with one of my colleagues that the numbers you are describing here, to me, are almost too good to be true. Not that I'm saying you are not, I'm just really impressed, because some of the kind of loss to follow-up and rates we are having, at least in my program in Nigeria, I actually would be very happy to have your 2004 retention, much less your 2012. So what I would like to know is, what exactly are you doing? Or is it just that, you know, people in Kenya are much better at going to the clinic? What exactly are you doing? Because I'd like to know.
So we always like to think we are better than Nigerians, although it may not be true.
No comment.
Basically, the clinics that we work in, and actually this strategy has been applied across all settings in Kenya, urban, rural, public, faith-based, you know, tertiary, secondary, primary. So the strategy does work. The key thing is there has to be a robust data system that both the facility and whoever supports them can interrogate and access. You need to know what's happening. The second thing is the facility staff need to have the capacity to not only find out what's happening, but to do things about it. So quality improvement capacity has to be built in to the programming. The third thing is there has to be a community element and a capacity of programs to support particularly vulnerable patients. Patients newly diagnosed need additional support. Those with comorbidities may need additional support. Those starting treatment may need additional support. So that should be built into the program. So patient case management as patients need it, again, is essential, so that some level of community support and community engagement can be arranged through the programs. So that is essentially the strategy, and we have shown that you can actually reverse trends even in programs with, you know, high loss to follow-up rates.
Yes, ma'am.
Sylvia, thanks for your presentation. I'm wondering how your results compare with, like, the national retention rates, and whether your retention rates have something with the fact that you're very rural. I'm just trying to find a reason to explain your very good results.
Yes. So I'm beginning to feel, you know, uncertain. We actually have a program that we're implementing within the city of Nairobi where we've actually demonstrated that the same strategy works. So it's really not just rural. About 30% of the facilities are urban, and each facility gets its own results. So again, you can show that it works also within an urban setting, even within the program. However, urban outcomes are poorer than rural programs in terms of loss to follow-up apps, particularly because transfer outs are more difficult to ascertain in an urban setting since patients get up and go, while from the rural setting they are a captive audience and they really don't transfer out unless they're leaving the area. So there is some element to which a rural setting lends itself to a much more robust management of loss to follow-up rates.
Could I also ask a question to delay our own presentation for a bit? When we see these interesting and encouraging increases in CD4 count at initiation in the previous presentation and in yours, there are of course two competing explanations for that phenomenon. One is that we increasingly remove the sickest patients from the pool of patients who haven't accessed ART yet and are not utilizing ART. And the other one, that given any CD4 count, patients behave differently over time because they are more motivated to come onto ART, or communication campaigns, social mobilization is more encouraging over time. And it would be very interesting to distinguish between these two explanations, because one is in fact more encouraging when we see that patients change their behavior, or people needing art are changing fundamentally their behavior, versus we simply have a selection effect, removing the sickest continuously from the pool of people needing art and not receiving it.
Yes, please. Podium 3.
Okay, thank you. My name is Dena Michael. I'm from Tanzania, and I'm a clinician. Thank you very much for a nice presentation. I would like to learn from you how did you manage to differentiate between those who were lost to follow-up to those who died, and what is the mode of your facility community linkage? Because we know if someone died in our setting, unless you have a very strong linkage, you may not know that this person actually died or just became lost to follow-up. How do you differentiate the two?
So the lost to follow-up is defined as anybody who doesn't come for an appointment who misses an appointment by more than 90 days. During that 90 days, activities take place. As soon as a patient misses an appointment, they are probably called by phone, or they call a community volunteer who lives nearby, and the process begins that may culminate in a home visit. In rural settings, it's not difficult to find out the outcomes of patients. Many of these facilities also serve as the hospitals where patients who are sick go to. So mortality can be confirmed because they died within the hospitals that we support, or because there is a direct community link with the family. You can call them, or there's a community volunteer that actually does that. The Ministry of Health in Kenya has implemented a community health strategy that does include quite a high degree of engagement with the family if it's implemented effectively.
Yes, last question, please.
I'm Penny Nayutung from AIDS Healthcare Foundation from Uganda. I just want to add to what the lady from Nigeria said. Presenting your data, it's a little hard to believe that you achieved up to 93%, retention rates. Even when you compare to most of the data, it's very hard to see that high rate of retention amongst ART patients, and also among pre-ART patients. It's even worse, even with as much effort as is made in regards to linking and retaining those patients. So I would want you to be a little more specific regarding what your actual interventions are, or what you did since 2004 up till now that has ensured that you have those high retention rates. In a little more detail.
I don't know whether there's time enough for me to do that, and maybe we can take that more specific
Explanations for your excellent results. So
I'm quite happy
what is your level of external support? Because if you're a millionaire, you can afford a lot of good things, and if you're poor, your performance will be less.
Right. I'd say that the model that was defined from the beginning almost guarantees generally good outcomes. One, if you have a database that essentially captures most of the information that you need, it is very possible to run an effective diary. Many of our clinics cannot even tell who is supposed to come today. And if you can't tell the person supposed to come today, you can't tell whether they missed an appointment. So starting with fairly basic things like having a diary that is accurate and that you can then use to indicate who did not come, and then that allows you to immediately act on the person who didn't come. That basic step begins the process of clinics being able to be proactive in managing their patients. Mobile telephone is very useful. The majority of our patients have access. Either they live with somebody who has, or they live close to a community health volunteer who has a phone. So the first step is normally calling the person or calling to find out if the person can be contacted. So those two things actually almost immediately result in addressing most of your missed appointments, reducing those who are likely to then go into loss to follow up. So then clinics being able to access their data, so even going forward and saying that, oh, in the past week, how many people didn't come back? That kind of thing, having a database that is accessible and interrogable. If that is maintained at the facility level, the facility then has a mechanism of being able to get the information that they need. And then also, facilities having the capacity to say we are not doing well, we can do better. So building quality improvement capacity at facility level. And we did this by developing multidisciplinary teams, many of which were integrated into hospital quality improvement teams, so that hospitals can actually by themselves say that we are doing this well, but we are not doing this well, so how are we going to address it? So building in the audit cycles or the PDSA cycles within routine clinic work. And this can be done even to the very lowest level of healthcare. And that is really our approach for all the programs that we support.
Thank you, Dr. Sylvia. I think while the findings are very encouraging, but we have to remember that this is a very close project at 29 facilities and a very limited number of patients. And when you have 600,000 patients, in whether how much of this can be extrapolated and the interventions that you use can be really applied in the real field setting. I will not take this as a real field setting that we have a real life scenario. But yes, these do provide that it is possible. We can do it.
Can I say also that in Kenya, this has been implemented in Nairobi City, so primary care urban settings, the tertiary teaching hospital, the 2 districts that are close to Nairobi, and within this program that actually has over 100,000 patients in care now. So it's real life. It's not a pilot. Thank you.
Thank you very much.